Okay, I'm here today in Chicago attending ASCO meeting 2019, and I want to speak about how I treat my newly diagnosed myeloma patients, particularly from our European experience in Spain. And first of all, we have to divide patients in transplant candidate and non-transplant candidates. And for the transplant candidates, what we usually do is we use a bortezomib-based triplet combination, and our standard is VTD, bortezomib, thalidomide, dexamethasone, which has a very good data. But probably now we would move to the VRD. We would substitute thalidomide for lenalidomide. Why? Because thalidomide is associated with some peripheral neuropathy, around 8 to 9%, a grade 3 peripheral neuropathy. So this could be improved by the switch to lenalidomide. And in fact, there has been a recent integrated analysis of two big trials from Spain with these two regimes, VTD and VRD, showing that VRD is associated with a better response, better progression-free survival, also associated with a higher incidence of MRD negativity, and also, very importantly, a better toxicity profile. So we would like VRD to be the next standard of care, and we are waiting for the approval of the EMA because we still don't have this agent approved, this combination approved. Probably in the future we will incorporate second-generation PIs in monoclonal antibodies, such as daratumumab, into these combinations, but for now VRD is our regime. If we move to the non-transplant candidates, here I think we have several options now. We have the MPV bortezomib-based regime, bortezomib, melphalan, prednisone, followed by len-dex, based on our trial we did in Spanish myeloma group in 2010. So MPV 9 cycles, len-dex 9 cycles, and probably what I would do is to continue the lenalidomide dex just as a maintenance phase, but only with lenalidomide, giving it as a continuous therapy. There are some other options now. Now we have the DARA MPV also approved, and which is, I think it's a good regime that also has this DARA as a maintenance phase. VRD would be probably soon approved also in Europe, and maybe in the future DARA RD that would be also approved. So I think we will have many different options in our country, in our region, and I think it would be difficult to decide which one to use in every patient. But I think this is good for patients because having different options is good, just to have different possibilities to choose.